Hi, everyone. My name is Jill Wodnick. I'm really honored to be part of the National Advisory Council to the Institute for Medicaid Innovation's National Doula Learning and Action Collaborative. And I'm missing you at the national convening because one of my kiddos is graduating from high school. So I'm going to miss being with you in Nevada. But I wanted to say my hellos and do a short segment about the doula workforce as you prepare to come together for Nevada. So let's get started and really just want to make our time together to acknowledge that there's an acceleration of states expanding and focusing on Medicaid reimbursement for doula care. Here's the most recent map from the National Health Law Project that recognizes that we have states that are actively reimbursing, implementation is in progress, action is proposed, or their current efforts underway. So wherever you are tuning in, there is something happening around you, regionally or specifically where you are from. But with all of this map to show movement, one of the things that the US Department of Labor has really documented that we may not have consistently acknowledged is expanding and diversifying the doula workforce with challenges of doula burnout and doula retention. So what this issue brief from the US Department of Labor found is that there's three primary concerns that move doulas out of the workforce. The first, negative interactions with clinical staff. Second, traumatic births without the resources to process them. And third, inadequate childcare for unpredictable on-call work schedules. As a longtime doula myself, I resonate with all of these challenges and burdens. And these were all things that really moved me to policy. And I do a small amount of labor support, but I do much more work with IMI and at Montclair State University. So I really understand the doula burnout and low workforce retention on a very personal level. And what I want to talk about today very quickly is one of the strategies that can be a protective factor to increase doulas wanting to stay within a complex system. And that is to have a designated advisory council for governance and shared decision-making. Now, listen, it's going to sound way more reductive and simplistic than I want this to sound, but I have limited time. So let's get to it. So first of all, in April 2025, the National Health Law Program author, Amy Chen, who's also on the NAC, has a wonderful issue brief called Best Practices of Medicaid Coverage for Doula Care. Part of what this report curates is that doula advisory boards or committees work for implementation and coordination. But what I want you to really hear is on this screenshot, the last sentence. It's important to note that these committees be set up to have explicit decision-making power, not merely serve as a toothless vehicle for advice or input, which could be ignored. How does this, what does this have to do with workforce retention? Well, it has to do something, because these are the states that are really recognizing that doula governance and doula decision-making for interagency coordination and collaboration is really, really important. I'm going to do a quick example of Michigan, and I want you to look at 4 dates coming up. So first, in August of 2021, there's a wonderful issue brief. And by the way, please put into the public domain what is happening in your state. We learn so much from community and local and state issue briefs. So here's an example of one called Policy Recommendations that Support Community-Based Doula Sustainability. This was published from the Black Mothers Breastfeeding Association, and it's abbreviated as BMBFA. They hosted the first ever community-based doula summit. They published a community-based SWOT analysis to optimize opportunities for the sustainability, availability, and accessibility of community-based doula care across Michigan. Then what happened? Well, the state of Michigan was moving ahead with their doula Medicaid policy. And this policy, or this benefit design from the Michigan Department of Health and Human Services, had a draft proposal. This draft proposal actually initiated an open public letter to the state of Michigan from doulas all around Michigan, where they said very clearly, quote, doula input was solicited but not used as the basis for policy. Why am I talking about this? What does this have to do with workforce? Well, look at this right here in yellow from the open public letter. The proposal as it stands is deeply flawed and will not result in the uptake by doulas. That's why we're talking about this, because shared governance and really making sure that doulas as decision makers becomes not just a pillar, but a really critical role of what states can do right now to either strengthen, expand, or initiate this decision-making capacity. Let me go a little deeper. Ultimately, Michigan did do the Doula Advisory Council, and it started with these 3 demands. The doulas were asked to identify barriers, create a doula survey, and then create a toolkit supporting doulas through an application process for Medicaid. Well, here they are now. The Michigan Doula Advisory Council really expanded well beyond those 3 beginning elements into comprehensive, systemic policy and program design. And these are actual doulas who are on the Michigan Doula Advisory Council, and these are their goals. So just take a look at this. This is wordy, but it's really comprehensive. So what is this council doing, and how does this relate to workforce retention? Well, as of October 1st, 2024, this council changed the benefit design to request and encourage and ultimately pass more home visits. This means that there's more opportunities for the doulas to build relationships pre and postnatally with families. And that means that the benefit can now be as high as $2,700. This council also removed the requirement for doulas to hold commercial liability insurance. So they removed a regulatory burden and increased the reimbursement, and they are keeping a diverse retained workforce. And most recently, in April of 2025, a Michigan Doula Medicaid Provider Toolkit was created and published. Please take a look at this wherever you are watching this from. Here is a screenshot. Part of what it does, how does this support the workforce? Well, it really curates and becomes very iterative about helping the doula to document for billing purposes, what did you address in a home visit? And it could be reinforcing practices known to promote positive outcomes. And it could be supporting personal and cultural preferences around childbirth. Or it could be identifying and addressing social determinants of health. It might be educating about newborn care, nutrition, safety, right? So this list really helps the doulas have an iterative understanding of how to document the time spent. There's also just an easy way to list the beneficiary's name, the ID number, the time in and out, all of this documentation. So here is just from the screenshot. A postpartum visit would be about breastfeeding or infant feeding, supporting personal and cultural preferences around early parenting. Look at this one, halfway down, educating on the identification of urgent maternal warning signs, or maybe grief support services, right? This really even helps the doulas document the interventions from physical support to emotional support. This is really important at helping the doulas feel that they can work within the documentation system for reimbursement. Labor and delivery has different ways of documenting that as well. And here we are. What about medical billing? Where it says right in the toolkit, medical billing can be overwhelming and time consuming. There's what to do if a claim is rejected, the different health plans, and different ways to go in Michigan. This is where you can find the toolkit. So I hope you will download it, and I hope you will see how this can be shared in your state, just to listen and learn about how the doula time is documented and iterative. We are gathering either in person or from Zoom for the national convening, and with all of the different states and regions together. I wanted to just end with all of the people that are coming together for DLAC. We have different from Alabama, California, DC, Nebraska, Nevada, Oregon, Texas. And this slide simply has the number of births per year, the percent of births paid by Medicaid, the percentage preterm birth, the percentage of cesarean and NTSV, low-risk cesarean birth rate. And I mention these because we need a diverse, retained, experienced doula workforce. Families need this, public health needs this, our state systems need working, experienced doulas. And so I believe that we owe it to our doulas, our community organizations, to take these best practices and share them. I'm looking forward to seeing you on Zoom soon. Thanks so much, everyone.